afternoon. It's my pleasure to welcome all of you to our introduction of InterRAI for community aged care physicians. We're very pleased to have with us Dr. Ng Wai Chong today. He will be sharing a case study with us to illustrate the impact and the usage of InterRAI in the community. And we're also very pleased to block your time and ask you to save your date. On the 11th of October this year, we will be holding our first Age Well Symposium and Age Well Championships. There will be exciting lineup of speakers as well as a lineup of interesting tournaments as well as prizes for those of you who have active aging centers. Please look out for the poster and the invitations, and you can start to invite your seniors and also train them up to take part in this competition with exciting prizes. Once again, I would like to also share with you that Home Nursing Foundation is the largest home healthcare organization, and we are happy to partner with you if you have any home healthcare areas that you want to develop in terms of home medical, home nursing, home therapy, as well as home personal care. And we are also trying to work with partners to develop Home Personal Care Plus so that we can provide comprehensive and holistic care to all our seniors as well as the aging frail population that we are serving. We have two daycare centers, one in Buangkok and Hougang, and one active aging center in Buangkok that serve seniors who are more robust and those who require dementia daycare. So we hope that this afternoon's program is very interesting for you, and please also feel free to invite your colleagues to join us for future installations of our CME. So take it away, Dr. Ng. Thank you.
Thanks, Christina. Okay, today we will have a similarly interactive session. I have prepared like 30 over slides, so I can only do one case study for everyone. The main idea is really an introduction. Once you get to use InterRAI and interpret it in your care for a patient, gradually you find that it's actually very easy to use, and it really changed the way we practice. So I'm going to just share what I know on how to use InterRAI for care planning purpose today. Okay, so if Kathy could help me let all the audience access the chat. Okay, so I changed the title a little bit. Instead of case studies, I just use case study, just one case. Okay, so how we use InterRAI assessment for care planning. So this is a very quick recap. We mentioned about the National Frailty Policy, the three-tier approach. As you can see, if a person is CFS 6 or worse, 6 roughly speaking, some basic ADLs, they are not independent. So many of the SEC and home care seniors that we see are already CFS 6, because if you are homebound, you're likely to have ADL impairment. But even if you're homebound without ADL impairment, just 4 or 5, the recommendation is to do ICOPE first stage. But I think if you remember, ICOPE first stage, you detect intrinsic capacity loss. If any one of them is deficient, you still have to do a comprehensive assessment. So 4 or 5 with one loss, you would still want to do a comprehensive assessment. So comprehensive assessment, you can look at the chart here too, will give rise to 3B. 3B, for those with losses in intrinsic capacities or functions or falls, we are supposed to have personalized and multidisciplinary care that addresses the medical, mental, and social needs, including referrals to relevant agencies and stakeholders. So today I'm going to talk about this one. Between care assessment and interventions, we need a care plan. So today we're going to talk about a personalized and multidisciplinary care plan. So let us also do a quick recap. So in a comprehensive geriatric assessment, you have all the various aspects of biopsychosocial and spiritual dimensions of a person's functional ability. And then in InterRAI, all of these are covered except spirituality. And then after the assessment, the last month when we spoke about InterRAI, we covered mainly the scales. Okay, so if you can recall, we have got the biophysical scale, the functional scales, the psycho-emotional scales, the social scales, as well as some risk stratification tools like MAPLE and CHESS, which I went through in details last month. So today I'm just recapping that this is it, and this gives us a visual of what the older persons are. The case study I'm going to show you, I will also share with you the scales in case you've forgotten how to interpret the scale. So this is a very, very quick cheat sheet. Higher score is worse, lower score is good. Higher score is weakness, lower score is strength. This is different from our modified Bartel, our MMSE, our AMT. So most scales, the higher the score, the better is a person. But in InterRAI scale, the higher the score, the worse is the person's functioning. Okay, so pain score 0 to 3. 2 and above is daily moderate, 3 is daily and severe. PURS, which is pressure ulcer risk score, the higher the worse. So this one you can intervene so that the risk score can improve. There's no cutoff score where you know that there's a pressure ulcer. Pressure ulcer is an assessment by the nurse or the doctor. BMI, there's no range, but we know that for people above the age of 70, even 22, ideal weight for us is too low. I mean, it's already at risk of malnutrition. Aggressive behavior scale, 5 or more is considered severe. But in my own experience, this is not from InterRAI, but my own experience, 2 or more, maybe in Singapore, caregivers, many of them are already stressed if you're 2 or more. Communication scale is really a measure of aphasia, both receptive and expressive. And so 4 or more, you will need to, the communication will be triggered. You need to have some kind of either speech therapy or communication kind of intervention. CPS score 2 and above is considered having dementia. 1 is maybe MCI, but 1 or 2 probably require a doctor's assessment already if you have not been diagnosed with dementia. Depression rating scale 2 and worse. Generally speaking, there is high likelihood that there is clinical depression. Deaf-blind scale 3 or more means both eye and ear already decline. Okay. 6, a person is totally blind and deaf. ADLH and is a hierarchy for the basic ADLs. ADL long form is if you want to rehabilitate, the long form can give you the granularity of improvement or decline based on your rehab intervention. ADL, IDL functional hierarchy is similar to our CFS. It's just a combined ADL and IDL as a person decline. So you can treat it like your CFS. IDL capacity and performance are taken together. Capacity is what you think the person can do. Performance is what the person actually do. So the difference in C and P tells us whether there's rehab potential. Okay. And then CARE is a risk for caregiver burnout, and VPR is vulnerable persons risk is really about rescue in case of a fire or a disaster. These are people who are ADL disabled, cannot don't have mobility, and there's some social isolation. Then we need to prioritize them for rescue. So this is a very quick recap of all the skills. Today we're going to do a care plan. So I'm going to share with you a case. I think this is a real case in Bukit Batok that I didn't see, but it's presented to me by the social worker in Ng Wai Chong Hospital, and then we were doing some kind of community work around there. It's a real case, but I might have embellished a little bit to illustrate a certain point. I'd like you all to read the case and then answer 2 questions. Please use the chat to answer the question. So this is Madam THB, has been our client for many years. I mean, you see, our webinar is targeted at doctors, right? So you're a GP or a polyclinic doctor, or maybe you're a home care physician. The patient had been seeing you for diabetes, hypertension, and hyperlipidemia, and you've not seen her since January this year, so it's about 4 months. The social worker has conducted a comprehensive assessment using the biopsychosocial template, not InterRAI, but a BPSS template, and has a copy of the recent discharge summary. So she presented this case to you, hoping to seek your guidance and work with you on a care and treatment plan. Okay, so this is an 81-year-old lady living in Bukit Batok, 2-room flat. Got diabetes, hyperlipidemia, hypertension, ischemic heart disease with atrial fibrillation, OA knees, osteoporosis, recent acute and chronic CKD. But baseline creatinine is 120, so this is still about above 25 GFR. So recent admission for agitated behavior due to UTI, so maybe delirium. Discharged with a follow-up with renal, auto, eye, and psychogeriatrics, maybe because of the agitated behavior. Long list of medicine, about 14, glipizide, metformin, losartan, simvastatin, cholecalciferol, calcium, paracetamol, apixaban, omeprazole, Capentec, Fosamax, olanzapine, Senna, and lactulose. The social worker, the template is very good. It covers some common symptoms like pain. So there's mild, moderate pain at her lower limbs when she walks. Weight is 66, height is 1.6, BMI is 26. No recent LOA or LW, loss of appetite or weight. Drinks very little because of frequent urination. Urine incontinence around 1 to 2 times a week, not able to reach the toilet in time. BO frequency is uncertain, but the stools are hard. Last fall in 2023, last year, outdoor, on the way to the market because of uneven ground. The vision is poor. There's bilateral cataract. Hearing is okay, skin is okay, and no shortness of breath or cough. In terms of function, she walks independently, holding on to the walls and the furniture. ADL is independent. Homebound otherwise. Medication served by the daughter in the morning and at night, not able to use the phone. In terms of condition and mood, speaks clearly and coherently, and she's polite to the social worker. She has poor memory because she kept asking the same questions. Since the discharge, she would be agitated and asked to go home, especially at night. Wakes up at night accusing the daughter of keeping her unlawfully. Lost her way coming home 2 years ago. Since then, she had been homebound. Not seen to be depressed. Okay. Socially, she's widowed with 2 children, a 54-year-old son and a 50-year-old daughter. The son is married with 2 kids, one in NUS and one in NS. Works as a Grab driver. The daughter-in-law is a homemaker. She lives with the unmarried daughter who works as a cashier at FairPrice on shift. She's alone at home when the daughter works. Financially, they are okay. The main concern by the client, okay, the caregiver, is that she's stressed. When the mother is alone at home, she needs to take leave to bring the mom to the many appointments. The mom's behavior, and then caregiver doesn't have enough sleep, and mom has incontinence and not sure what else she needs. So that's the social worker's report. So I'd like you to use your chat to answer the first question. How would you begin to develop a care plan for a patient like Madam THB? You got all this data. How do you begin to do a care plan? Okay. Is the chat open? Oh, maybe the chat is not open. I think y'all cannot access the chat. Okay. Let's yes, can. Okay, the chat is open for all now. So please type, how would you begin? Okay, someone say apply for dementia daycare in the daytime. Okay, so you apply, and then someone said test. I think she's testing. Okay, anybody else sent to daycare? Medical escort. Yes, because the daughter is stressed that nobody bring her to the doctor. So you send her to the medical escort so that she can be brought to the doctor. But the problem is, how to open the door, right? Unless you don't lock the door. If you don't lock the door, I don't know whether it will work because the mother at night thinks that she's being locked unlawfully. She may actually open the gate herself and get out of the house. Somebody say hire FDW. Yes, indeed. This is one good option in Singapore. This is a luxury for Singapore. But we know in the community that some seniors die also do not want a foreign domestic worker. Apply for dementia daycare, just now somebody say, right? Of course, that is really good, but there's no diagnosis of dementia. AIC will tell you, oh, cannot, no diagnosis of dementia. Home personal care. Well, she's ADL independent, so the home personal care maybe is to do house cleaning, but it might not solve the daughter's problem unless we can help her to jaga the mother, because her stress is due to the mom alone at home and may fall, right? Caregiver training for the daughter. So the daughter say, you can train me, but I don't really need training. Maybe lah. I mean, what's there to train, right? Caring for person with dementia. Yes, but you are like, you haven't solved my problem. Or maybe you have. So caregiver training, frequently we refer patient for caregiver training, but I understand from sources that most of the time family members send their foreign domestic worker for training rather than they themselves go for training. Send mother to daycare. Yes, that's a good idea, provided the mother wants to go to a daycare. But the nighttime behavior will still be unsolved, right? Somebody say review by GRM for BPSD. Well, yes, she's already got psychogeriatrics. She's on olanzapine. So maybe the geriatric doctor can offer more, but most of the time they are not living with the patient, so that's all they can do also, to prescribe medicine. And olanzapine can increase the risk of fall, increase appetite, make it worsen the diabetes. All this may actually happen. Caregiver support group, yes, provided the daughter is free to attend. But is her issue related to emotional? Well, maybe. So sometimes I believe for stress caregiver, we need to analyze what are the needs before we advise whether caregiver training, caregiver support, or financial and so on. We need to find out what is the need. Review the medication list. Yes, that's good because it's very long, 14. 14 sometimes is appropriate, but if you look at it, there are some medicine that may potentially worsen the function of the patient. I mean, one example is olanzapine. Another example is anticoagulant. If she have a fall, she may actually have bleeding, but I'm sure they have assessed that the fall risk is not so high. Homage, yes. Homage is timed, there's they go to the house for a certain period of time. Would they be able to cover the whole day until the daughter return? But when the daughter return, what about the nighttime behavior? So the stress is not just about jagaing the mom. There are also other things, right? So Harati says it suggests day rehab to reduce risk for frailty. Daughter can rest when she's there. Yes. And then explore if you're able to afford a helper, consider daycare, siblings, and so on. Active Aging Center, explore ACP. Okay. I should give, I mean, Krishna said explore if family is able to afford a helper. They have no financial issue, probably they can. Helper can come. This is one good idea. So, but of course, we know in community case management, sometimes it's try and error. Sometimes it works, sometimes it doesn't work. They care if the helper is available. Inform that they can employ a helper if they can get help from government. Ask your any sibling. She's got a son. Midday meal when daughter is not around. Explore other financial issues. So financially, they seems to be okay, but the stress by the daughter is really more about the urine incontinence, nobody to juggle the mom in the daytime, nighttime behavior, and perhaps and the fall risk. Active Aging Center, yes, but Active Aging Center, they may not be funded enough to take care of somebody with behavioral issues. But maybe she behaves well in AAC. So sometimes AAC may work for somebody like her. Sure. Explore ACP. Yes, ACP is always relevant. Especially for somebody, like in this case, could be early dementia, we should do ACP. Daycare so helper can care at home, can rest and correct her vision. Yes, bilateral cataract, maybe the eye surgeon is to review whether she should go for a cataract. Family members take turn to care. So there's a son who is a Grab driver and the wife is a homemaker. So he's probably the sole breadwinner. They have got two kids, one in NUS and one in NS. So the one in NUS may need to be financially supported. Okay, night respite and so on. Okay, let us stop here for a while. The issue is I was hoping somebody could say, before we do a care plan, we should identify what are the problems. So let's do the next part. What do you think are the problems in this case? What problems and care issues can you identify? So let us do on the chat a brainstorm. just pick whatever problems you see there are and then type onto the chat. Let's do a brainstorm. I will capture onto a piece of paper. Okay. Polypharmacy, yes. Somebody say constipation. It's actually with Widyawati. And then agitation. There is pain. Yes. Anybody else? Fall risk. Yes, fall risk is definitely an issue. Anybody else? Incontinence. Pressure injury, the thing is she's able to walk, so maybe not so, but incontinence itself, wet the floor, rushing to the toilet, all increases the fall risk. Okay. Then pressure injury, for somebody who is well nourished and walking around, usually not so high. But she got diabetes. So good point. Maybe we have to watch out for feet, at risk feet, because she's got DM. She's got poor vision, cognitive challenge. There's no diagnosis of dementia yet, so cognitive loss may be a problem. Caregiver stress, very good. Constipation, urine symptoms, urine incontinence, polypharmacy. So very good. Many of you are poor food intake. Well, the nutrition seems to be good, but it was a social worker who reported this. There could be maybe pedal edema, she got history of IHD with AF, so the weight may not be a real dry weight. So maybe she is malnourished despite the good BMI. Good point. Why we suspect poor food intake is because she does not drink enough water. So water not enough. Food BMI is good, but who knows? It could be edema related. So nutrition is a concern. Okay. Anybody else? Risk of institutionalizing, yes. Because if the daughter give up on her, say she's very stressed, I mean, sometimes caregiver stress, you may not know how bad it is. And then want to send her to institution. But for her, if you understand the current nursing home criteria, she may not qualify, but she may qualify for an ALF. Today news, the sandbox for ALF seems to have some good development. Yeah, so maybe she can go to assisted living facilities. Behavioral issues, sleep disturbance, yes, sleep disturbance is an issue. Behavioral issues, yes, she has got this behavior, especially in the evening time. Okay. Okay, very good. Hypoglycemia. Hypoglycemia is an acute issue. We have no evidence that there is hypoglycemia in this case presentation. Loss of weight possible because she also not eating due to cognitive impairment, right? But so far the BMI is okay. There's no, from the social worker's brief history, there's no loss of appetite or weight so far. Oh. Okay. So far I had polypharmacy, constipation, agitation, pain, fall risk, incontinence, at-risk feet, behavioral issues, urine incontinence, caregiver stress, risk of malnutrition, and sleep disorder. Anyone consider functional issue and social issue? Social issue, there's possibility of caregiver stress. But do you think she's socially isolated, home all the time, not interacting with anyone except the daughter? We don't have information about the son visiting. Financial issue currently with the assessment by social worker is no, but we should always be observant for that. Okay, so there may be social isolation. Is there a possibility of abuse and neglect? In this case, probably not. No? Yeah, so socially isolated is an issue. So the social isolation and lack of activities may actually cause her to be very frustrated at home. And this causes a lot of challenging behaviors, lack of community participation. Yes, we do not know what's the biography of this person. She could be an auntie who is very outgoing, very socializing, right? The other thing is function. IDL, she can't even make a phone call. If she has any emergency or any problem, nobody knows, So this is a care issue. Okay, thank you very much, your participation. Yes, lack of activities can lead to functional and mental decline, and functional decline can lead to bed sore. So you can see that a person like recently admitted for UTI with delirium and then discharged, now home, and then we are focused on caregiver stress, but we sometimes miss out on other things such as social isolation, lack of activities of engagement, and so on. So, and also when we throw out to the floor, if the audience is mostly clinicians, doctors and nurses, we might be biased towards clinical issues. Perhaps if I were to do this to a group of social workers, they may identify more, maybe the caregivers, intra-psychic issues, her own future care plan, maybe her maybe social isolation, maybe elder self-neglect or neglect, such issues. I don't think she has lah. And also there isn't anything mentioned about home environment. So I would also ask about that. So I'm trying to illustrate that we can begin to do a care plan by flushing out all the care problems. But when we flush out the care problems, we are limited by our training and our perspective. If we are a doctor, we will think like a doctor. If we are a psychiatrist, we will think like a psychiatrist. If we are a nurse or a social worker or a psychologist or an OT, we will necessarily be thinking along that line. We are also restricted by the place where we practice. If you're a GP in an ambulatory clinic, you'll probably be paying a lot of attention to the chronic diseases in the second column. You may not have insight into the care issues and the home environment and the functionality. But say if you are RC, resident committee volunteer, what you look at is you probably be seeing that the caregiver, probably you come from a more social perspective. Caregiver is stressed. How can I help? Should I refer this person to a nursing home? You may think along that line. If you are a doctor practicing in the emergency department or the hospital, you will also have the perspective from where you work. So this may become a limitation to how we can flush out care issues, and that will also make our care plan potentially make our care plan biased. Okay, so I will now explain InterRAI. How do we use InterRAI for care planning? So this is also a slide that you should be familiar with. InterRAI is like a black box. We enter the information through our eyes and ears and reading the NEHR and observing what they do, speaking with the family and the patient if she can talk. Then we enter into the system according to the standardized manner. And then this system has an algorithm, okay, to produce based on billions of data with research. So it's really like I think it sounds like some kind of machine learning, but it's not real machine. It's actually done by a lot of academics. So based on that, they produce all the clinical skills, and today we're covering the CAPs. The CAPs you can see are in the center. Altogether, there are 21. There are 12 clinical CAPs. There are 6 psycho-emotional and cognitive CAPs. There are 5 functional CAPs, and there are 2 socio-economic CAPs. I will go in detail in the next few slides. What are CAPs? CAPs are care foci, care issues or problems. So our common language we call problem listing, but problems sometimes sounds negative. Some issues are not problems, they're just risk. we can improve on the function of the person by overcoming the risk. They may not be problems yet. So in InterRAI, we use a neutral language called CAPs, Clinical Assessment Protocols, or Collaborative Action Points. Okay, and the unique is a unique feature of InterRAI. You enter and then it will share with you what are the areas that you can do something about based on international literature and large data. Okay, they are not intended to automate care planning, but rather they are designed to engage us to have a dialogue, to have a collaborative care plan with the patient and the caregivers. So these care issues are usually issues that if you do something about it, you can have meaningful improvement in the quality of life. For example, all appendectomy, it will not generate as a CAP. Or somebody with severe dementia, totally bedbound and so on. Cognitive loss will not be produced as a care issue because there's no point, working on the cognitive loss. So, so this is the CAP. And in the CAP structure, it covers the description of the problem, the overall goal of care, and what triggered this CAP to surface. In a way, it's like a transparency into the black box. What are the items you tick that cause this CAP to produce? To me, this is useful because this is also where I can critically think what is relevant, what's not relevant, or because sometimes the trigger may be because of wrong input. Maybe the assessment is may not be actual. But most of the time it is quite all right because looking at a lot of data. But sometimes if like urine incontinence is triggered and I don't see the patient, I don't think there's urine incontinence, I will study the assessment done by either the nurse or the allied health, and then to see why did this person trigger urine incontinence. So it helps me to critique the study. In the CAP, you have got the guidelines, but I'm not going to cover today because they are very long. They are like care protocols developed by international experts based on references, and then the additional resource. I'm going to give you one example. So this book is given to all the social service provider for free by AIC. Otherwise, if you purchase online, it's about $80. So this is one example, cognitive loss CAP. These are people with cognitive impairment at the early stage, okay, where you can do something about it. So the guidelines I'm going to cover today, but I can give you a glimpse. If a person is triggered cognitive loss, if there's no dementia diagnosis, we are supposed to see whether we should let this person consult a physician for a diagnosis. And then we should also check for function, because cognitive loss is just cognitive, but is there impairment in IDL, ADL? And can this person work? And then and if there's impairment in function, we need to look for musculoskeletal disease, neurological disease, and we need to look for reversible causes of cognitive loss in our assessment. So you can see this guide is used by case manager who could be nurses, social workers, may not be doctor, but I guide them to say, what should a doctor do? What should you ask a doctor for comment? Are there behavioral symptoms? So what else? Is this person suffering from depression? Because depression sometimes can present with cognitive impairment appearance. Are there other medical conditions? Can this person communicate effectively with others? Is this person involved in daily life? And should we look for opportunities for this person to continue involved in daily life? What is the extent of rate of change? Could there be something more drastic happening? Is a person experiencing failure to thrive, losing weight and losing their function? Is this person having developmental disabilities? Because persons with intellectual disabilities tend to have dementia at an earlier age. So these guidelines help the care manager to look for other things to work on. But one of the first advice is, if dementia has not been diagnosed, please refer to a doctor for assessment. This is just one example I'm going to do. The rest of the CAPs, I'm only covering the goals of care as well as the triggers. There are 21 of these, so bear with me. I'll do it relatively fast. After that, I'm going to share with you how we use InterRAI to apply in the same case. How do you do care plan? Then I'll invite you all to talk about interventions also. Okay, so appropriate medications is triggered because there's a risk of medication-associated morbidity. The goal is to promote proper pharmacological management. It is triggered when there are more than 9 medications and has 2 or more of these issues, dizziness, edema. That means long list of medicine doesn't mean you have polypharmacy. I mean, doesn't mean they are inappropriate. If you've got long list of medicine and there are some symptoms that reason deterioration, maybe there's you need to look into appropriate medications. Bowel conditions, okay, this is a long one. So it's to address 3 common issues: constipation, diarrhea, and fecal incontinence. There's a risk of decline and the risk of improvement. If there's a risk of decline and there are only 1 or less risk of decline and 2 or more risk of improvement, then we should aim to improve on the bowel continence issue or constipation issue. Otherwise, we just want to prevent decline. So this is, when it's triggered, this is why it's triggered. And then for cardiorespiratory symptoms, is to help the case manager manage an older person with cardiorespiratory conditions and refer to the physician accordingly. If there are chest pain, shortness of breath, irregular pulse, dizziness, and high or low blood pressure or SaO2. Dehydration risk is to trigger. When it's triggered, it is for the case manager to assess for underlying cause, to rehydrate and prevent complications. So high risk is when they're dehydrated and symptomatic. Low risk is dehydrated but not yet symptomatic. Falls is a little bit contentious for InterRAI. The look back period for fall is 90 days, 3 months. If you had 1 fall, then you're into medium risk. If you've got 2 falls or more, then you are in the high risk group. If you have no fall in the last 3 months, it will not be triggered. So a lot of us, sometimes we see a case and the fall is not triggered. And but me and my nurse will discuss, I think there's risk. Let's do something to prevent. But why is the threshold for fall so high? That's because all the frail elders who are able to walk are all at fall risk. If you trigger everybody for fall risk, then you might as well make fall risk prevention a basic intervention with or without fall risk. So that's why they purposely put the threshold a little bit higher. But in practice, sometimes I look at this case, I will sometimes add a fall risk to do some intervention for. This is from my own experience. But if you look at the CAPs itself, not triggered means you're not mandated to act on it. I mean, if there's such a thing as a mandate, but it's really a guide for us. Feeding tube, a lot of patients on feeding tube, there are 2 groups. One is with decision-making, one without decision-making. The purpose is that those with decision-making, we are supposed to explore ACP and explore with the patient whether feeding tube aligns with their own principles and goals and values to be more person-centered. For people without decision-making, having this feeding tube cap is so that we can properly manage it, the frequency of change, the caregiving training to the caregivers, how to maintain the feeding tube, how to prevent complications. Pain, high priority is severe pain even if it's not daily. Otherwise, it is daily pain, mild or moderate, then it's considered medium. Okay. Then for pressure ulcer, it's not based on the pressure ulcer risk scale. It's based on whether there's a stage 2 ulcer or worse, or stage 1 ulcer, or have got a few risk factors for ulcers. If they got a few risk factors for ulcers and stage 1 ulcer, then we will trigger the CAP called pressure ulcer. And then we will need to have some care plan around pressure ulcer prevention or healing. Prevention is also very interesting. There is an item called whether the person has seen a physician in the last 3 months. If the patient has not, it will be triggered. Apparently, frail elders should see a doctor once every 3 months. If there are no other people, no nurses or physician assistant, seeing the patient, according to their standard. They also have this interesting standard called colonoscopy in the last 5 years. So if you have seen a physician, but no BP check, no colonoscopy in the last 5 years, no dental exam in the last 1 year, no eye exam in the last 1 year, no hearing exam in the last 2 years, no influenza vaccine in the last 1 year, no mammogram in the last 2 years, no pneumovax in the last 5 years, it will be triggered. So when it's triggered, we will need to review, is this aligned with our Singapore criteria? If it is, like indeed, flu vaccination is recommended. Pneumococcus, we should do it 60 years, two kinds and 1 year apart, right? So we will need to, it reminds us to make sure that they're up to date in vaccination, mammogram, and so on. Mammogram for Singapore, I think for older women, we don't really do it. But I checked, there's no upper limit age for mammogram in Singapore. So I think it's based on clinical. Tobacco and alcohol, I find in Singapore, it's not so common. Drinking sometimes happens. So it triggers when a person CAGE criteria positive, felt the need to cut back, need to drink the first thing in the morning, had 5 or more drinks in 14 days, and daily smoker. So if triggered, then we will bring it up and discuss with the client. Would you like to quit? Undernutrition is based on BMI alone. Less than 16 is severe, 16 to 17 is moderate, 18 to 22 is considered mild. Then we will look into the nutrition need. Urine incontinence is either to improve if you look at the triggers, they got recurrent episodes of urine incontinence, but some cognitive ability, able to walk independently or at least mildly dependent. So people like that, we can improve on the continence. Otherwise, then it's just to prevent further decline. Okay. For ADLs, the purpose is to facilitate improvement once it's triggered. That means this person had rehab potential. Is in a way, is an automatic decision support. Although rehab potential usually is a doctor's discretion, we do it based on motivation, cognitive function, and the reason. How recent is the loss of function, right? So, but it triggers if the person is not totally dependent, and CPS is not extremely severe. That means the dementia is not extremely severe, no risk of imminent dying, and have a recent acute event, then there should be rehab potential. We should do something to improve on the ADL. Otherwise, if you don't fit the criteria, then if this is triggered, we are supposed to prevent decline. That means do maintenance ADL. Let the person do as much as possible for him or herself. Physical activities is triggered if the person is not getting enough exercise and the person is of relatively good function. Okay. Home environment optimization is based on home safety for risk. So in InterRAI, there are certain things to check. It's hygiene, the squalid conditions, the lighting, clutter, and so on. So if there are any of these, then we will, there is a home environment optimization. Institutional risk is when a person is at high risk of going to a nursing home. That is because 4 or more of the following: any stay in long-term care in the last 5 years, short-term memory problem, any deficit in cognitive skills, Alzheimer's disease, any limitation in making self understood, any limitation in understanding others, any of the behavior issue. So this case, Madam THB, has not been diagnosed with Alzheimer's or dementia yet. Let's say she is diagnosed. She would have short-term memory problem. She would have Alzheimer's disease. She would have wandering and abusive behavior. Okay, she may not still fit the criteria for institutional risk, but let's say she, because of a hearing impairment, she sometimes cannot understand others. If 4 are triggered, then this person would be high risk of going to a nursing home. And the intervention, if you read the book, it will be about supporting caregiving and improving community setting support. Daycare center, foreign domestic workers, all will be relevant for this particular CAP. IDL is to preserve current IDL function or to improve it. For psycho-emotion, cognitive loss is very interesting. If your cognitive loss is very severe or moderately severe, like CPS 3 or more, it will not trigger already. Because this one is to prevent decline or risk of decline, that means there's still cognitive function that is sufficient for decision making. We want to preserve. But if you're 3, 4 or more, the main thing is to ADL, IDL activities, well-being. Is no longer about preventing decline or monitor for risk of decline because it's already declined. So just a reminder, CPS 2 is already diagnosable with Alzheimer's disease based on the corresponding MMSE scoring. Okay, communication. Of course, I was saying so loosely, diagnosing AD require more, but generally CPS 2, chances are this person has dementia. Okay, communication is about aphasia. Some of them can improve if they have sufficient decision making, but some of them don't have very good decision making. Is about preventing decline. So that's where speech therapists or occupational therapists can come in. So you can see with InterRAI, it covers different aspects of the training of the nurse or the doctor or a social worker. I mean, honestly, a lot of us as physicians, sometimes we forget about the need for communication rehabilitation. So this system sort of trigger it for us to refer to someone, to look into this. Abusive relationship, okay, because time is running a bit short, I underestimated my speed of speaking. So abusive relationship triggers the risk that this person is a victim of neglect or abuse. And then behavior is challenging behavior. There are a few things that will trigger this. Wandering, verbal abuse, physical abuse, socially inappropriate disruptive behavior, inappropriate public sexual behavior, and resistive behavior. So if they exhibit any of these behavior daily, then it is triggered. And if it doesn't occur daily, then it's triggered to prevent it from occurring daily. So how do you prevent or manage? That is another story. Okay. So Philip Yap last year, shared with us about dementia, and his team actually shared with us about this. So behavioral management is a whole thing in itself. Delirium, it uses CAM to help us detect. So if a case is found to have delirium triggered, the case manager need to consider whether should I get the person to go to A&E or get a doctor to see this person as soon as possible. Mood. Okay, so this is based on DRS. As I mentioned before, 3 or more, the specificity for depression is nearly 70%. Sensitivity is about 90%. So we cut off at 3 and above. So once it's 3 and above, maybe there's depression. 1 or 2, there's some low mood. Low mood, in our current mental health strategy, right? There are tier 1, tier 2, tier 3. Tier 2, you should still do something, like activities prescribing, social prescribing, and maybe counseling. Okay, social relationship triggers for social isolation, and informal support refers to a person who is not independent in IDL or ADL, and yet there is not enough informal support, not enough caregiving at home. Okay, so I've covered a brief rundown of all the CAPs. It covers, you can see the system, clinical, psycho-emotional and cognitive, functional, and then social. They're all together 4 groups of CAPs. So how do we use InterRAI for care planning? First, you do a comprehensive assessment using InterRAI. In the care plan, for a doctor, I will quickly glance through the InterRAI items, mainly I look at the scales and the CAPs, then I will just go through anything to highlight. In the RISE-OFF system, sometimes the nurses will make remark, the assessor will make remark, so I will also read that. But if I'm short of time, I'll just read the scales and the caps. If I and based on that, then I will go and see the patient after that. Then I know what to focus on. Then review the caps. What are the problems, what are the goals, what are triggers, and what are the guidelines? You can use the book to go through the protocol, but I find that useful. Maybe we can organize everyone and then we learn this like a in-house training course. But when it comes to actual care of the patient, not practical to always refer to the guidelines. Maybe AIC will make it automated onto the software and then we can just click. But in a way, by just simply clicking and not really reading, also not very valuable. So it's important for us to use our training, to plan what are we supposed to do for each of these caps. Then you set priorities. This I find for complex patients, just a list of care foci, it may not really help. I need to know what is the most urgent thing. Then I'll focus on that. And then you can modify, adjust, as I mentioned. Some of the things like falls, the system doesn't trigger, I may want to trigger it to act on it. Sometimes it's other things like, for example, poorly controlled diabetes. InterRAI doesn't show you this, but if I am a home care doctor, I may highlight this and as a in a way artificially. The software that we are going to use from RAISoft will allow us to trigger the items that are not traditionally caps. We can just trigger it and then we do a care plan around it. So in a way, although it's automated, you still need clinicians' experience and training to really make the care plan even better. But if you don't do that, just based on the automated caps, it's good, it's not bad, it's at least standard, okay? Then we communicate and negotiate care plan with the client and caregivers. So all these are based on clinician discretion, and then we intervene according to the caps, okay? So as I mentioned, for complex patients, sometimes we don't know which care issues to address first. Then we need to set priority. The priority should be based on the ACP or the current care preferences, values, and goals of the senior and their caregivers. Then, but if they have no preference, then you just go by Maslow's hierarchy of needs, it's physiological needs, safety needs, and so on. And which one is the most critical is also based on your experience. Sometimes you know they are very complex, but the most critical factor is a caregiver support. Then I will focus on caregiver support. Sometimes it's very complex, but the most important thing is medically where I need to stabilize. Then I need to first focus on the poorly controlled heart failure or poorly controlled COPD. Then the caregiver stress, everything should settle rather than tackle everything all at once. So sometimes we need to use some discretion. So I'm sharing with you because many of you are clinicians. So even though this is an InterRAI talk, but we need to apply our own training experience even when we read the InterRAI data. So back to this case. So this case, so you can use your knowledge of the reading the scales. So this person, IDL is 44, so it's almost maximum. That's why she's homebound. Performance, that means she's not doing, maybe a bit that she can do perhaps is taking her own medicine, or maybe using the remote control, or at least preparing, making a pot of, making a cup of tea for herself. So this is just a bit of retain some IDL performance. If I compare performance, I would like to see the capacity at the bottom, 44 and 44. So IDL wise, at least the social worker doesn't think there's a potential for improvement. So IDL may not improve, okay? ADL is dependent. So yeah, so this is definitely CFS 6, okay? Long form is 4. So if I were to do some rehabilitation, maybe the ADL long form can improve further. Okay. BMI is 24. It's actually 26. Chest score is 1. So if you remember the last time for home care patients, if the chest score is 4, more than 50% chance of passing away in the next 6 months. In nursing home, 3. Okay, so chest call can predict prognosis. Communication is intact. CPS is 2, so no diagnosis of dementia, but there are symptoms of dementia, so we should let the doctor assess this case. DRS is 2, so not clinically depressed, probably. PRS is low risk because she's able to walk and she's nutrition is good. Self-rated depression is 0. Pain is daily pain, but not severe. That's the OA knee, right? MAPLE score is 3. So MAPLE score is the urgency. How do you've got many cases, you go for MAPLE 5, 4, and 3. This is prioritizing. It's for triaging. It's for re-stratification. Aggressive behavior scale is 2. As I mentioned earlier, 5 is serious, but in my experience, 2 and above, caregivers are already stressed. These are the CAPs. So in this case, ADL is triggered to prevent decline because she has got sufficient cognitive function. She should be able to encourage to do the ADL herself, even though she's quite dependent on ADL. Institutional risk is triggered high. Okay, this was just how we felt this case, institutional risk was already high. Cognitive is triggered to prevent decline because it is only 2. And we should keep her engaged with activities, maybe even cognitive training to keep the cognitive function. Okay, communication, there's a risk of decline. Mood, triggered because it's only 2 points, so it's low risk. Pain, medium priority. Dehydration is high, not drinking enough. And maybe having some symptoms already, like constipation. Prevention, no physician visit in the last 3 months. Social functioning means social isolated is triggered. So these are the CAPs triggered. So how do we, so these CAPs will be translated into care plan. So in the software that we will be using, currently, I think many CCMS are using AcuteNet, but in the future, we'll be using a different format. But the gist is the same. So in terms of the CAPs, there are 4 categories. Clinical in this case, pain, medium priority, dehydration, prevention, ADL, general risk, cognitive, communication, mood low is low risk, and then social function, which is social isolation. So the purpose of the pain is to relieve suffering, optimize function. Okay, dehydration is to address underlying cause to prevent complications. Physician visit or prevention is to make sure the preventive measures identify and action taken. Okay, so even for her, 81 years old, but still functioning quite all right, and mild cognitive impairment only, there may be a case for vaccination and certain health screening, probably not the cancers, but some other kinds of maybe checking the feet and the eye, right, because of diabetes are still needed. ADL is to prevent decline. So going to a daycare center, or if you hire a helper, we have to guide the helper to make sure that she should still be able to shower herself and walk and so on. Institutional risk, the idea is to prevent premature admission to a long-term care facility. So in this case, we really need to organize the community resources to support the caregiver, to support the mother, including perhaps hiring a foreign domestic worker or getting her to a daycare. But before that, she needs to be diagnosed with dementia first. And of course, caregiver need to be trained and supported. Cognitive function is to prevent decline. So various measures, communication, prevent decline. So improve on the eye and the ear, and maybe cognitive training. Mood is low risk. Social functioning is to increase social engagement. So someone suggested AAC. I felt that's a good idea because she doesn't probably qualify for SCC. She may qualify for dementia daycare, but she may also enjoy going to active aging center. Initially, I wanted everybody to participate to talk about interventions, but I think we are nearly 3 o'clock or already 3. So let me just finish my slide. I got one more thing for everybody to discuss. So types of interventions. There are so many things we can do, okay, for each of these care focus. It's not just about medications or referring to a specialist. We can do further assessment, like the case manager can do an MMSE or a MOCA, can do a detailed environmental assessment. The doctor can order some lab and x-rays. We can refer to specialist outpatient clinic or community services. We can review the medicine in order to either add, to subtract, or to adjust the doses. For nursing care, we can do health monitoring, medication management to help them pack, or to maybe certain nursing procedures are needed. Health monitoring like diabetic retinal photography or feed screening or dietary counseling. Care navigation is information and referral to the various community health and social services, health coaching, social prescribing, brokering for goods and services, caregiver support, clinical communications like doing ACP, explain condition prognosis, LPA. We can unlock financial schemes and community resources by getting disability assessment or PG-DAS, advocacy and other interventions. So we may want to read up on certain condition. If you're a nurse or a doctor or a social worker, we can actually do our own research or check with our colleagues. We can do ACP. We can explain diagnosis plan, do family conference. We can have a meeting with other service providers. Okay, so as a doctor, you may want to talk to the care manager, but you say you're very busy in your work in the PCN, maybe the PCN coordinator can help us conference with other service provider, right? Other conferences, maybe meeting with certain steering committee or local government. What is the role of the doctor in the face of this? So in the audience, I know even though we are targeting at community aged care physicians, but there are many of you here who are case managers, nurses working in nursing homes, nurses working in a daycare center. So a lot of time, and also particularly, I think 30 over of you are or 50 are doctors. So what is our role, in the face of this aging of the population, and then using InterRAI, and the languages is not exactly medical diagnosis, but they are, if we are trained in geriatrics or gerontology, we'll know that these are real life things, functional. So our role is to review the assessment and have a picture and make diagnosis behind the symptoms, the scales. For example, in this case, the CPS score is 3. It is 2. Somebody need to diagnose dementia. The urine incontinence is there. Somebody will need to know, is this transient causes or is it a kind of established cause of urine incontinence? If there's hard stools, could there be a CA colon? So the doctor are still needed to go behind the symptoms. So sometimes the case manager may come to us with these CAPs. Then we will need to know what is our role here. We can also make prognostication because some of the preventive medicine depends on what we expect the life expectancy of the person is. Also, rehab potential is usually a judgment by the physician because we will need to refer for rehab, and at least from what I can remember, the IMS still require the doctor to say the person is fit for rehab. Then disease management decisions like the diabetes, hypertension, how strict do we want to control the diabetes? Preventive health decisions need to be relevant to the family and the patient. Reviewing medication is very valuable, long list of medicine, which are the one we need to remove. Fiduciary assessment, such as LPA, disability, the society trusts us to sort of be the gatekeeper for these expensive resources, so we will need to shoulder the risk. Clinical communication is very, very important. A lot of time, family are very stressed until the doctor explain to them the facts, the evidence, and the assessment, and it allay anxiety more than caregiver training can do, frequently. So the doctor's role in clinical communication is very important, and it only can come from a doctor. I'm not putting the nurses down. Usually, serious issues, family expect the most senior of doctors to sort of explain to them. But of course, when they don't agree, they'll talk to the nurse in private, okay, usually. Then the nurse and them, they can really smoothen the communication. The last slide is for everybody to participate. I would like to ask you, Now that you know doing care planning with InterRAI and without InterRAI, what do you see are the differences? Maybe I'll invite you to use the chat and just type. What do you see are the differences with InterRAI and without InterRAI? It's standardized and more focused. Yes. Thanks, sister. More structured. I don't know about you, but if I have a junior nurse and a senior nurse, if they're all equally trained in assessment, I don't have to worry that the junior nurse will miss out on things because the assessment is relatively standardized. Okay. And also with the standardized assessment, I can even get a social worker to do the assessment. And I will be quite confident that the clinical issues, the nursing issues will also not be missed. If I get a volunteer who is trained, in fact, when I visited Canada many years ago to see their InterRAI implementation, they train mid-career switch community care workers in InterRAI assessment. It really saved a lot of cost. But as you can see, clinicians' training experience is still important. It's not automatic that care plan will be produced like that. Okay. So Dr. Seong mentioned that there is a common language. Yes. Otherwise, we will use modified Battelle, we will use FIM, we will use AMT, and so on. So sometimes we hear a person use a certain scale, and then I never heard of this scale, then I'll feel very paiseh, okay? Also, fall-risk score, you know, there's this fall-risk score, FRAT, F-R-A-T. It's non-standard, you know. Different country have different version of the fall-risk score. So if you have different scales, sometimes we do not know what are we talking, are we comparing apples with apples. So if you don't have same language, you can argue until the cows come home. Nobody can say that you are providing over-servicing or under-servicing. Okay. We prioritize according to care needs. Yes, so it produced the care needs. InterRAI doesn't quite prioritize. We will need to assess the whole case and then we will see which is a priority of the case. Someone say more efficient at a system level for policymakers and payers. Yes, indeed. Because of the aging population and the rising GST, okay, aging population is expensive for any health system. So if you want to pay for aging population fairly, equitably, inclusively, accessibly, you need a system that doesn't under sort of shortchange anyone, but also doesn't pay more for people who ask for more. It's more, in a way, standardized for everyone because resources are never enough, no matter how wealthy a country is. So somebody says accurate. It depends on how well you do the assessment. So according to, I forgot to mention, this particular webinar is a collaboration with AIC. Sister Faiza, you all have met before. She innovated a way that we need someone in the service agency to occasionally audit others' assessment because she said that without this, the quality assessment can decline. If quality assessment decline, it will be garbage in, garbage out. And when she presented to the International InterRAI Committee, all of them really adopted this idea that it's important to have a champion within a service agency to ensure the accuracy of the assessment. So it is accurate so far as the assessors is accurate. Okay. InterRAI care plans can be shared among professionals. Yes, you can see the care plans is not medical, it's not social, but it is biopsychosocial and functional. And functional, if I remember, I mentioned long ago that in the lecture about frailty, in the end, what is health to an older person when diseases will happen by nature, you know? health is no longer the absence of diseases, but it's about functional ability. So you can see functional ability play a big role in InterRAI assessment. So Robert mentioned that it's comprehensive. Yes, yeah, it's biopsychosocial and quite standardized. Early detection, better interdisciplinary communication, quality assurance. Yes, one of the aspects of quality assurance is consistency, right? And also, we won't be doing this, but InterRAI will produce a series of quality indicators that is evidence-based, that has variation across different agencies, and intervention can change. So these are very good quality indicators. If all of us in InterRAI, one day we can use it for quality monitoring. Good for interdisciplinary communication because the language is neither medical or social. Early detection because it is done on a regular basis, 6 monthly recommended. And long-term care, you really boil down to long-term care, it is all about prevention. Prevent suffering, prevent complications. It's tertiary of quaternary prevention. So it's early detection to prevent things from getting worse. The psychological needs and caregivers are systematically addressed. So thanks for all your participation. You had them. I think you have captured the gist. I wanted to illustrate with InterRAI, without InterRAI, there are certain differences. Okay, so and if we use InterRAI, this is how we use it, but we will still need the clinicians' experience and training. So we still need to go for our CME on dementia, on continence, on geriatric syndrome, and so on. They're still important. Okay, so it's 11 minutes past 3. Are there anyone with any questions? If not, maybe I invite Christina for the close. Okay.
Okay, I just want to thank everyone for your attendance and to remember to save your date for the 11th of October for our Age Well Symposium and Championships. So take care and have a great weekend. Bye, everyone.
Bye-bye.
Thanks, Dr. Ng. Bye.
Bye.